Good afternoon, students. Here again, we will see the another session of dosage regimen pattern, dose therapy according to pharmacokinetic and disease patterns. So, in which we will discuss the dosage designing, how we will give the dose, how we will decide the dose according to the disease and disease patterns. So, this is the second lecture of the topic. In this topic, we will start with the design of dosage regimen and multiple dosing. Here, dosage regimen is the manner in which a drug is taken. It is selection of drug dosage, route, and frequency of administration in an informed manner to achieve therapeutic objective. What is our goal? Our goal is to attain the therapeutic concentration, to produce the effect, means that drug must produce the efficacy, and by producing that effect our disease will be, or disease symptoms will be overcome. That will be our goal. So here we have to define, or we have to decide the dose or route of administration or frequency in such a way that it should not increase the dose or it should not decrease the dose, and it should maintain the dosing parameter or concentration of the drug in such a way that it will produce the positive therapeutic effect. The duration of most illness is longer than a single dose. Therefore, to prolong the therapeutic effect, multiple dosage regimen is preferred, because during the prolonged or longer treatment, just like in case of tuberculosis or leprosy or fungal infections, skin infections, or in case of cancers, we prefer the longer therapy. We require longer therapy for that disease or that conditions. So in that, a single dose is not sufficient. So for that, you have to take the drug for longer period, for more frequency of dose will you require. So before taking that drug for longer frequency, we must evaluate their effects, we must evaluate their pharmacokinetic property, we must evaluate their dosing, that how much dose we have to give at how much frequency, that we have to ascertain before giving that therapy. So here we are doing that same thing we are doing by monitoring way. We are controlling our therapy, we are controlling their effects, we are checking their effects, we are controlling the doses also, and also we are check out the dosage forms as well as route of administration to identify the correct dose, to correct dosage regimen, correct route of administration, and correct frequency of dose. That four things we are going to be find out here. Now here the students, which you can see here, this is the graph of a drug. It is an example of any drug. If you are taking any drug, how it will produce the graph. Now if you see, the graph has been plotted, the concentration against the time. This is the time and it is the concentrations. Now at this point we are giving the drugs, or patient is receiving the drug. Once he receives the drug, immediately the concentration will start to rise. Slowly it start to rise. And here at this point, what is this? This is the minimum effective concentration, means from this concentration and from this time we will get the effect of that drug. Suppose this time will be near about 10 minutes, so from 10 minutes we will start to get the effects, and at this concentration we will start to get its effects. Now again it will start to rise, the graph will increase its concentration into your blood slowly, and at this point it is the maximum concentration of the drug into our blood, and it is also called as Cmax. So it is the maximum concentrations. Now once it attains that maximum concentration, from that point it will start to decline its concentration. Slowly it will decline its concentration into our blood, and after few period it will again attain the minimum effective concentration. So from the point at which we have start to get the effect of that drug, and up to the point at which we have got or the effects has been reflected. So in between this period it is called as duration of action. Means after this point, as the time will progress, suppose 10 minutes it required to start the action, again another 15 minutes required to got the Cmax. So another half an hour, or suppose 1 hour is required to complete or to have a duration of action, and after that it will start to decline the concentration. As the concentration declines, the effect also will decline. The drug won't show any effects, and finally here it will slow down and it will come to the polar position, come to normal zero cut position. So here means up to this point we got the effective concentration, or we got the response of that drug. And between this minimum effective concentration it is the and maximum therapeutic concentration, means above this concentration we can't get its effects. So these two between these 2 points it is nothing but the therapeutic range. Means whatever drugs we are receiving, that must be given in this therapeutic range. If you are giving, and the drug decide its therapeutic range, different drugs are having their different own therapeutic range. Some drugs are having high margin of therapeutic range, some drugs are having very narrow therapeutic range. So in case of narrow therapeutic range, we had to give the drug very cautiously, because if you will give the drug more than maximum therapeutic concentration, it will start to produce the toxic effects. And if you will give the drug below than minimum effective concentration, it won't show its effects. So that's why in that condition we have to do that very smartly. We have to do the drug very smartly. An optimum dosage regimen is one in which the drug is administered in the suitable dose. That's why by considering all these parameters, we must give the suitable dose of that drug with sufficient frequency that ensures maintenance of the plasma concentrations within the therapeutic window. We must give the drug and its frequency in such a way that it should not increase the concentration more than maximum therapeutic effects. Now, within the therapeutic window, without excess fluctuation and drug accumulation, means there should not be more fluctuation. Like when you are driving any vehicle, suppose we are driving a bike, so how you will release the clutch and how you will increase our speed, so here that decides. So slowly we have to release the clutch, and slowly again we have to increase the speed. Like that the same thing is here. Suddenly the no fluctuation should be there. Suddenly we are increasing the dose and suddenly we are decreasing the dose. It should not happen. You should maintain the steady state concentration. Means your dosage or your concentration of the drug in the blood should be revolve into this margin, into this interval. It should not low down here, it should not go ahead than this. So it is called the perfect dosage designing that we should do. And for the longer period, we should design our therapy in this manner. Now here we will discuss the approaches to design the dosage regimen. How we will design the dosage regimen. Now the first way is empirical dosage regimen. When we are working on large number of populations, so by our experience we are start to calculate the dose and we are deciding that this dose is sufficient or perfect one for these peoples. For example, we can for pain as a painkiller, paracetamol 500 mg is perfect dose. So by our experience, by working on the lots of populations, we can do this. It is an empirical dosage regimen. Same thing in case of antibiotic like cefixime or cefuroxime, or in case of macrolide antibiotics or quinolones. So by our experience, we can decide when we are working on large number of populations. So it is a common formula or common planning we are deciding for any sort of disease condition or any comorbidity. Now here individualized dosage regimen. It is a dosage regimen which we are designing or defining for the specific individual, for a specific person, because person to person variation will occur. The dose which we are giving to the A will not produce the same effect the dose which we will give to the patient B. That difference may be there. So that's why we have to individualize the dosage regimen according to the patient's health status, his body weight, his age, sex, his physical health, uh, disease status. According, by considering all things, according to all these things, we have to plan, we have to design the dosage regimen, and it is called as individualized dosage regimen. Now, dosage regimen on population average. So here there are two parameters. One is fixed model and another is adaptive model. What is fixed model? It means we are giving the same formula, same frequency for all the populations. For example, quinolones in the disease of malaria, in Plasmodium vivax. So we are giving the fixed doses, means we are giving the 500 mg doses into multiplication of 6. So for first day we are giving the 2 doses, next day we are giving the one, and after again 2 days we are giving the one dose. So in divided doses we are planning. So same therapy, or in case of the infection, bacterial infection of E. coli, suppose. So in that we are giving the cefixime. So we are giving the dose of 200 mg divided multiplication by 6, means 2 times a day for 3 days, means total 200 mg multiplied by 6 means 3 gram dose we are giving. So it is fixed model. For any therapy it is a fixed model. So by either by fixed model we are treating the patients, or adaptive model, sometimes we have to do the adaptation according to the conditions, environments, according to the disease status, health status, age, sex. We are doing the adaptation into the model of our therapy and our frequency. So we are doing some modification, we are doing some amendment into our therapy. It is called adaptive model. Now here dosage regimen. It can be divided into two types. One is dose size. So what size of dose we are giving? Suppose paracetamol, what we are giving 500 mg or 100 mg or 1 gram, or in case of antibiotic like macrolides or tetracyclines. So we are, the dose varies. So it may be 10 mg or 100 mg or 1 gram. So that decides. So dose size. Next is dose frequency, means we are giving once in a day, or in 2 day once a time, or once in a week, or twice in a month, or 2 times in a day, or 3 times in a day, or 4 times in a day, so or hourly. So that defines, that decides your conditions, dose frequency. Sometimes you have to give the drug, in case of some antibiotics, in case of very critical conditions, 3 hoursly. Three After 3 hours we have to give that drugs, that injections, or that intravenously we have to put that drug into the drip. So like that, that conditions decides. So dose frequency, so that decides. So in case of eye drops, you are giving 2 times a day or 1 times a day, or only at night. So that the drug and the dosage forms, that and disease condition, that decide this dose frequency. Population averages. Calculations are based on the compartment open model. What are the calculations we are doing? That depends on the open model compartments. And pharmacokinetic parameters remain constants during the course of the therapy because the ADME will be the constants. So the whatever drug concentration we are giving to our body, so whatever times it required to absorb, it is a constant. For distribution, it is also constant, and also for metabolism as well as for excretion. So it will be the constant one. Here, dose size. Now, how will you decide the dose? How will you plan the dose for any new drug which has been which is going to be entered into the market? Before that, we are doing the clinical trial, and it is a part of clinical trial. Pharmacokinetic department is the part of clinical trial. It is a primary part of clinical trial. So here we have to decide the dose. Any clinical trial, if you want to run, first you have to plan the dose, and here the pharmacokinetic plays a major role. The magnitude of the both therapeutic and toxic responses. Therapeutic response means at which dose we are getting the effect. It is called therapeutic response. And toxic response, at which typical dose, at which specific dose we got the toxic response. So we had to check out for both the responses and both the concentrations, at which concentration we got therapeutic and at which concentration we got the toxic responses. Depends on the dose size. So if dose will increase, we will get toxic response. The dose we will give the therapeutic dose, we will get the effect of that typical drug. And if you give the less than therapeutic dose, you won't get any therapeutic effects. The dose size calculations requires the knowledge of amount of drug absorbed after the administration of each drug. Yes, we must know the absorption of that drug, how much time it required to absorption, by which way it will absorb, and how fastly or by which route or by which organ it will absorb. That we have to identify and find out. So that decides our dose size as well as our frequency of dose. Because once the drug will absorb into your body, it will go to your bloodstream, it will go into your systemic blood circulation, and from that point it will start to rise into your systemic blood circulations, and once it will attain one point from which it will start to show its effects, and at one point it will start to show its toxic effects. So that 2 points we have to find out. Now, factors to be considered. So, these factors to be considered when you are deciding any dose, when you are formulating any dose of any drug. So, here first parameter is pharmaceutical parameters, pharmaceutical factors. So, in the pharmaceutical factor, one is type of dosage forms. So, what type of dosage form we are preparing? Either it is tablet, means single dose, tablet, capsule, or we are preparing any elixir, means we are preparing any liquid preparations, or we are producing any parenterals, either it is IV or intramuscular or intradermal or subcutaneous, or we are going for the topical preparations. For example, it may be cream or ointments or any body spray or any external use preparations like eardrop or eye drops. So like that, any formulations, what formulations we are giving, according to we have to decide the dose size. Suppose we are giving any drug by intravenous route, it require very less dose. Suppose if you are giving any drug by intrarectal route, it require somewhat more drug. And again, if you will give the drug by intranasal route, again it require somewhat more drug. And if you are giving the drug by single dose like tablets or capsules, you have to give the large dose. So like that, that defines our dosage forms. Same thing happens in case of our route of administrations. Now as we are discussed, from the oral route we will start. Oral route, because in oral route we had to go through the process like bypass, first pass method. So it is a first pass method, which will take or consume more drug, because the number of or percentage of drug is also going to bound to our plasma bind. So there will be less drug for its activity, for its should show its effects. So that's why in case of oral route we require more drug. After an oral route, if you'll go for the nasal route, it requires somewhat less drug. After nasal route, if you go for the intrarectal route, again it requires somewhat less drug. Again from the intrarectal route, if you go for the parental route, so in case of parental route, it requires very less drug as compared with the oral and intranasal and intrarectal route. And for topical route, obviously it requires a larger dose, because it won't go directly into our systemic blood circulation, or it require more drug to go into our systemic circulations. So in this fashion, the route of administration also decides our dose and size of our dose. Now, patients related factors. Now, patients factors or patients conditions will decide the dose of that drug, any drug. First is individual patient's tolerance of the drug. Just a minute. Okay. So here, individual patient's tolerance of the drug means how much quantity of drug can be tolerated by the patients. If patient's tolerance is high, in that condition, we have to decide the dose high. If intolerance is there, in that condition, we have to give the drug very cautiously. By thinking for a number of times, we have to decide the dose. So that decides on your tolerability of your patients. If tolerance is good, you can give the sufficient amount of the drug. Next is genetic predisposition. Nowadays, it becomes very critical. Genetic predisposition. It is a condition when the person's genes, the person's genes are becoming vulnerable for, it becomes, the genes phenotype becomes vulnerable. They are affected by the environment as well as drugs. Means for specific peoples who are having specific genetic uh, characters, they are more vulnerable for typical diseases. Now, for example, if you see, there are certain peoples who are more prone to cancer. Some genetic groups are there who may suffer from the blood pressure, means hypertension. Some are, some may suffer from the obesity, means from the genes. It is called genetic predisposition. Means here some typical genetic vulnerability is there. Genetic phenotype will be affected by the environment as well as some few drugs, just specific drugs. So it can affect on your health. There are certain peoples, or I will give some example. For example, the peoples who are having o positive, they are more prone to have acidity. It's a fact. I saw lots of patients who are having o positive blood group. They are having more prone to the acidity. Sometimes they may develop ulceration also. Now, concurrent administration of other drugs. So when we are simultaneously we are adding another drug also. So at that time we must check the drug interaction of that another drug with our current drug. So that is also very important things, because if you won't consider, it will produce a drug interaction, and it will take the life of patient also. So we cannot sacrifice in this manner. So here the concurrent administration also is very important. What drug we are giving with these drugs? So if it will produce some toxic effects or any adverse effects, we should give this dose very less, or we'll try to avoid the dose with that drug, or we'll avoid that another drug with this drug. Now, patient's age, yes, obviously it always correlates with the patient age. in case of mostly in case of kids or the oldest peoples who are above 60 years old. So they will require less dose as compared with the adult dose. Next, body weight. The persons who are having less body weight below 50 kg, so they will require less dose. And the persons who are having more body weight or heavy weight, so they require more dose as compared with the low body weight persons. So that decides your body weight. And gender, obviously, in case of female, we can't give the drugs very friendly. And in case of males, the males are as compared to the females, they are more strong. So more dose can also be tolerated by this male. So like this, gender. And also in gender, another condition like pregnancy or lactation, so in that condition also the dose plays a great role in that. Next is length of illness. For how much period we have to give that drug? That illness will prolong for how much period? For example, cancer or HIV or tuberculosis or leprosy or skin disease, or in case of hypertension or arrhythmia or diabetes. So in this disease requires longer treatment. Another is in case of epilepsy, it also requires longer treatments, or migraine. So these are the diseases which require too much longer treatments. So in that, we can decide the dose of the drug, that how much dose we have to give, how much safe dose we can give. Because if we give higher dose for longer period, definitely it will produce the toxic effects. So we cannot do that too much easily. So we have to decide the dose according to the length of the illness. General physical health. Yes, what is your general physical health? If it is good, our physics is good, we are not having any allergens, we are not having any intolerance. Because lots of patients are people are having glucose intolerance. So in that case, they have to take the drug very cautiously. Or some people are having allergy of some drugs or some conditions, some environmental condition also, some fruits are also. So general physical health, it should be normal. If you are having low immunity, in that case we have to think the dose of the drug. Next is liver and kidney functions in the patients. If your liver and kidney are not in good conditions, if they are diseased, if they are not functioning well, in that condition also we have to think twice or thrice before deciding any dose. Because a small increase in your dose or small addition of the dose of your drug, it can increase the problem, it can take life also of your patients. In case of kidney, renal failure will occur. In case of liver failure will occur. And to tackle with this condition, it will be very difficult. It will lead into the multi organ failure, and which is very critical conditions. So these parameters, these physical health parameters of patients, that also is very important when you are deciding or when you are preparing any dose size. So here again we have discussed the another lecture on these dosing parameters. Because dosing parameters, we must understand how we are deciding the dose, how we are designing the dosing parameter, how we are deciding the dose of any drug. Because we are going blindly in the clinical trial, we don't know what drug or what dose of that drug we should start with. So that's why we are doing this pharmacokinetic study before starting our clinical trial. Once you fix to your dose, after that we will start the clinical trial in large number of doses. So this is the primary stage of our clinical trial, phase 1. It is very important. So here we are primarily we are more concerning about the our safety of our drug. That's why safety means if your dose is normal, if it is good, if it is not non-toxic, means your trial will be safe. So students, I hope you understood these points. So remaining we will consider, will start in next lecture. So it is sufficient for today. I hope you understood the whole concepts. Thanks a lot for hearing me.